Hi guys, and welcome back to my channel The Medicine Quest. Today I am taking up another topic, diabetic and hypertensive retinopathy. So before we begin, I'd like you guys to like this video, subscribe and support this channel out. So let us start with the topic hypertensive retinopathy. Before we get into the clinical features and gross characteristics of it, let us understand the pathogenesis of this disease. So this first involves the phase of vasospasm. That is, there is the primary response to raised blood pressure and there is vasospasm of the vessels. Then there is the arteriosclerotic phase, which reflects the duration of hypertension and it involves the thickening of the blood vessels. Then there is the phase of increased vascular permeability. Now how does this happen? Hypoxia in the blood vessels and this region leads to the breakdown of the inner blood retinal barrier, and this leads to increased vascular permeability, which causes hemorrhage, exudates and other features which we will talk about. Then there is the raised intracranial pressure, which occurs because of malignant hypertension or accelerated hypertension in the form of optic nerve ischemia and papilledema. So let us see the features in the form of the Wagner classification. This is the most important part and it will help us solve the questions. So the grade 1 of this classification involves arteriolar attenuation, that is narrowing of the blood vessels, and the normal ratio of the arterioles and veins is 2:3, but in this grade it becomes 1:3. The second grade involves the Seleucine, which is the deflection of the veins at the AV crossing, and also involves marked narrowing and attenuation of the vessels, but the most important part is deflection of these veins, of the optic veins at the AV crossings. Then there is grade 3, which involves the bonnet sign. We can remember B for bonnet and B for banking of the veins distal to the AV crossing or the arteriovenous crossing. Then there is the gun sign, which is the tapering of veins on either side of the AV crossing. So this is the grade 3 of the Wagner classification. Also in grade 3, there is something called as cotton wool spots. Now I will show you an image which will depict all of these features, but let us understand what is cotton wool spots. So cotton wool spots. Now cotton wool spots occur as fluffy white or off-white lesions in the fundus. And what is this? This is basically infarcts because of neuronal debris in the nerve fiber layer of the retina. And the next feature is flame-shaped hemorrhage. Now flame-shaped hemorrhage is a superficial retinal hemorrhage which also occurs in the nerve fiber layer, and this all occurs due to the breakdown of the blood retinal barrier, as I mentioned in the pathogenesis. So this leads to these features. Now what is copper wiring of arterioles? Now the normal arteriolar reflex or light reflex is the reflection of the light which is seen normally in the fundus of a patient. Now in this case, the reflected light occurs as a reddish brown reflex, so that is known as copper wiring, and it occurs because of the sclerotic phase of the hypertensive retinopathy. Silver wiring, which occurs as part of grade 4 of the Wagner classification, is an opaque white reflex which is seen in the fundus of the patient when we are examining them. Just like copper wiring, which is seen as a reddish brown, silver wiring is an opaque white reflex which is seen when the light is reflected from the retinal arterioles. It also involves papilledema, which is the blurring of the optic disc, and papilledema, as I mentioned in the pathogenesis, occurs due to malignant hypertension or accelerated hypertension. Now regarding the symptoms, the grade 1 and grade 2 are asymptomatic and does not lead to any symptom to the patient, whereas in case of grade 3 and grade 4 there will be symptoms present. Now what will those symptoms be? It could be a decreased or blurring of vision to the patient, and it may also involve headaches. Now if it is grade 4 and there is raised intracranial pressure as well, it will also lead to projectile vomiting. But the basic thing to understand it, yes, the symptoms will be present in grade 3 and grade 4, but not in grade 1 and 2. So let us look at this image which I have blacked out 7 features which obviously shows the hypertensive retinopathy. So let us try to figure all of these out. Before we begin, I'd like to take some time to get oriented to this fundus image, right? So in the center there is the optic disc which is visible. Towards the left side there is half of the macula, that is the blind spot, which is visible over here, and these dark red vessels, these are the retinal veins, and these light red vessels are the retinal arterioles. And now let us begin at looking at each of these features. So if you look closely at the number 1 features, the arteriole or the artery which is present, if you take a look at it distally over here, the caliber or the diameter of this vessel is thicker as compared to when it is near the optic disc. What is this? This is basically grade 1 feature, that is arteriolar attenuation, right? Now let us look at the second feature. We can see the artery over here crossing over the vein over here. This is AV nipping which is occurring, AV nipping, which occurs because of the sclerotic phase of the pathology which we discussed. And then if we look at the third feature over here, this, if you see, is the copper wiring, that is the reddish brown reflex of the artery towards the right. This is what grade of Keith-Wagner classification? This is grade 3. So after the third feature, the fourth feature. Now if you closely look at this whitish, off-white, fluffy white-like lesion, this is the cotton wool spot which I was talking about. Again, this is a feature of grade 3. Now if you look at the number 5th feature, there is this small hemorrhage which is present. This is the superficial retinal hemorrhage, and this is also the feature of grade 3. Now the second last feature, that is the 6th part, if you look closely at the optic disc, the margins of the optic disc here are very blurry and it is not normally seen over here, and therefore this is the blurring of optic disc or papilledema. So this is feature of grade 4. Now the last feature, the 7th one, if you look at this yellowish deposits which is present, these are the hard exudates or exudates normally called. This is basically the lipid deposition in the outer plexiform layer of the retina, which also is seen because of the breakdown of the blood retinal barrier as well, and therefore this is the exudates. Now if this is seen in the form of a star-like picture, that is called the macular star, it is a feature of grade 4 of the Keith-Wagner classification, which is seen in malignant hypertension. So let us look at this question here before us. So I'd like you guys to figure this one out yourselves and comment below on this video and let me know what grade you think this is. I've mentioned some arrows over here to help you out, and let me know on the comments below which grade of Keith-Wagner classification you think this is. So now I'll be continuing my talk with diabetic retinopathy. So the pathogenesis involved in this, the basic pathology which we need to understand it, is that there is retinal microangiopathy. Now how does this occur? This occurs due to the cellular damage which can be caused by intracellular accumulation of sorbitol or advanced glycation end products, or AGE in short form, protein kinase C activation, or excessive oxidative stress in the form of reactive oxygen species or free radicals. Now what does this lead to? This leads to the first change which is seen is the loss of pericyte. Now this occurs due to the cellular damage which has occurred as well as hyperglycemia, and then there will be breakdown of the blood retinal barrier as I just discussed in hypertensive retinopathy. This will lead to what? This will lead to the edema in the retina, Then it will also lead to hemorrhage as well as accumulation of lipids, which is called the hard exudates or exudates, because the hard and soft terminology is redundant as of now. So we'll just write exudates. Now this will also lead to weakened capillary wall. Now what will this lead to? This will lead to microaneurysms as well as hemorrhage. The hemorrhage which I am talking about right now is superficial as well as deep hemorrhages, that is the flame shaped hemorrhage, which is the superficial hemorrhage, or dot and blot hemorrhage, which is the deep hemorrhage. We will all look all of these features into in detail soon. Then microvascular occlusions which lead to ischemia. Now this ischemia occurs and we can see the cotton wool spots because of this, as I just mentioned previously, that the neuronal debris will cause ischemia and then it will lead to the fluffy white cotton wool spots. So now this microvascular occlusion will also lead to a thing called IRMA, or intraretinal microvascular abnormality, which is basically a arteriovenous shunt which occurs because whenever there is microvascular occlusion in a retinal arteriole, the part distal or the retinal part distal to that blocked arteriole will now be supplied by another vessel, which is a shunt vessel. So this IRMA is basically the shunt vessel which is supplying the part of the retina distal to the occluded arteriole. Now chronically, when this ischemia is present, which will lead to a phenomenon called neovascularization via the factors VEGF, that is the vascular endothelial growth factor, PDGF, platelet derived growth factor, as well as HGF, that is the hepatocyte growth factor. So now we'll be looking at the ETDRS classification, or early treatment diabetic retinopathy study classification. This involves three parts, that is non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, and then diabetic macular edema. So first we'll look into the non-proliferative part. So the earliest finding which can be seen in this case is microaneurysm, which can be seen as a red dot-like structure on the fundus exam. It can also involve intraretinal hemorrhage, which can be superficial, as I mentioned before, that is the flame-shaped, or deep, which is a dot-blot hemorrhage. Cotton wool spot, as explained multiple times now, is the soft exudate, which is a misnomer. But what is it exactly? It is infarct of the nerve retinal fiber layer. Yes. Then there will be exudates which will be present, that is accumulation of lipids. Then venous beading or looping. This is basically, there will be certain parts of dilation and then constriction and then dilation in the veins, which can be seen forming a bead-like or loop-like structure. This is what is known as venous beading. Then progressing further, IRMA, that is the shunt vessel, as I mentioned before, that is the intraretinal microvascular abnormalities, can also be seen. Now what is the treatment for non-proliferative diabetic retinopathy? Now if it is mild or moderate, it can be treated with observation only with regular examinations 6 to 12 months. If it is severe, we may also try PRP, that is the pan-retinal photocoagulation, or we can also try anti-VEGF drugs. As I mentioned, that proliferative or neovascularization occurs due to some factors, and some drugs against those factors will help in the treatment of this condition. Then we will look at proliferative diabetic retinopathy. Now the hallmark for this type of diabetic retinopathy is neovascularization. Now this can occur in two forms. It can be neovascularization of the optic disc, that is NVD, or it could be neovascularization elsewhere along the fundus, so that is NVE. Now some two other points which we have to note is that there may be also fibrovascular proliferation, which will lead to vitreous hemorrhage as well as tractional retinal detachment. Now this occurs because the fibrovascular proliferation causes the traction, which will lead to retinal detachment and further will aggravate the condition. Now rubeosis iridis is basically when there is neovascularization of iris, there will be improper drainage of the debris, which will lead to secondary glaucoma. Now the features of non-proliferative diabetic retinopathy can also be seen along with the neovascularization, and vision loss will occur due to vitreous hemorrhage, retinal detachment, or secondary glaucoma, as we have already discussed. Treatment for this is the same, that is pan-retinal photocoagulation or anti-VEGF drugs. I have mentioned one example, that is bevacizumab. These are the only treatment. Of course, we cannot leave it to observation only, so here we have to focus more on the treatment part. Diabetic macular edema. Now, macular edema, there is the retinal hemorrhage which I have just mentioned in the pathogenesis. Then there will be retinal infiltration with lipids as well as fluid. And when there is significant retinal thickening and edema around the macula associated with hard exudate, which will lead to this condition. Now, vision loss, it may also lead to vision loss because of this macular edema. Now, one thing we have to note is that this stage, that is diabetic macular edema, can occur in any stage of non-proliferative diabetic retinopathy or proliferative diabetic retinopathy. Treatment is similar for pan-retinal photocoagulation or focal or grid laser therapy. Just the affected part of the retina will be irradiated with the photocoagulation laser, or we can obviously try the anti-VEGF therapy depending on severity. Now, some images which I would like you guys to see to note down the features and understand it better. Now, this image conveniently shows us all the features, right? The cotton wool spot, which was common in hypertensive retinopathy, which can be seen as fluffy white lesion. Then towards the left side, this small dot-like lesion which is seen, that is the microaneurysm, which is the part of non-proliferative diabetic retinopathy. Then there is the hard exudates, that is yellowish lipid deposits, which is seen near the macula. These are the hard exudates. And then hemorrhages, which can be easily visible in the screen. Now, the second image I have mentioned here because I wanted you guys to see how proliferative or new vascularization looks like. So, in this image, in the lower right side, you see the proliferation of new vessels. This is the new vascularization. Here it can be seen in the left bottom corner as well. Even in the top, you can see multiple places with new vascularization. Other than this, there are other lesions and other characteristics as well, but this image I wanted you guys to see, especially the new vascularization. Now, this third image is just for your information, like after pan-retinal photocoagulation for the treatment, how does the fundus look like? So this image is basically showing that only. So all this spot, like yellowish spot like thing you see, is basically the photocoagulation which is occurred or done in the whole of the retina over here. So this was the basic features. Now we will look at some clinical features and how the screening is done for diabetic retinopathy. Now, in early stages, usually the patient is asymptomatic. There may be symptoms according to the complications, as we have discussed, like macular edema, vitreous hemorrhage, or retinal detachment. These will lead to blurring of vision, as well as floaters, photopsia, scotoma, sudden and painless loss of vision, as I have just mentioned. Later stages, there will be significant visual impairment, which will lead to blindness. Now, screening, there's only two statements which we need to remember. That is, for type 1 diabetic retinopathy, the screening is to be done within 5 years of the disease onset or when the disease has been diagnosed. In type 2 diabetic type 2 diabetes mellitus, we have to screen for diabetic retinopathy at the time of diagnosis. And that's the end of my talk for today. And I hope you guys like the video. Please like and comment your answer for that question as well, and also support the channel for future content.